Hi, my name is Alessandra Dornty. I am a FNP student at WTAMU. This will be my video filming my head-to-toe assessment. I will first pan the room. I will be performing my assessment on a 44-year-old male patient who has come in for a general physical. We have already completed the general survey, going over his medical history, surgical history, allergies. He is alert and oriented. He is allergic to penicillin and not currently on any medications. I've obtained his height and weight. I've obtained his vital signs, which were all within normal limits. I've tested his vision using the Snellen E-chart, and he has 20/20 vision. And I have washed my hands, and I will now begin the exam. I will first inspect the scalp, making sure that it is symmetrical, making sure there's no bony prominences, noting the texture and distribution of the hair. I will feel the temporal pulses, making sure they are 2+. Also, throughout the exam, I will be noting skin color, texture, moisture, dryness, as well as looking for any suspicious moles or nevi. I will then test the patient's trigeminal nerve by asking him if this feels dull or sharp on each side.
Oh. Taller. Tall. Taller.
Okay. I'm also looking at the patient's face to make sure eyes, nose, and mouth are midline symmetrical as well as ears. I will palpate the frontal and maxillary sinuses, checking for any tenderness. I will also palpate the temporal mandibular joint, asking him to open his mouth. I should be able to fit 2 to 3 fingers behind the jaw. You can close it and move it side to side, making sure there's no prominent popping or clicking of the jaw. I will then move on to the eyes. First, inspecting the sclera, making sure they are white, no yellowness indicating liver disease, as well as the conjunctiva, making sure they are pink, no redness or paleness. I will test the 6 fields of gaze. You can follow up and adjust your eyes. Perfect. I will then check for pupil accommodation by having you look at the pen light and look at the wall behind it and the pen light. Perfect, making sure the pupils constrict appropriately. And then I'll also use the pen light to check for consensual and direct constriction with light. So if you'll just look at me, we have direct and consensual and direct and consensual. Perfect. I will then look at the optic disc with the red reflex, using the same eye as the eye that I'm looking in on the patient's side, and using my hand against their forehead to brace, making sure I'm looking for any papilledema or any abnormalities. Okay. So then moving on to the ears, visually inspecting, making sure the ears are symmetrical, looking at the exterior of the ears, palpating for any tenderness, nodules, swelling. I will look inside the ear canal. In an adult, I pull the pinna up and back before inserting my ophthalmoscope, and I'm making sure that the tympanic membrane is pearly gray, no redness or bulging that could indicate infection. Perfect. I will then test the patient's acoustic nerve with the whisper test. If you can just repeat what I'm saying. 99.
99.
And 66.
66.
Perfect. I will also conduct the Weber and Rhine tests. The Weber test listens for lateralization. So I will hold this on the top of your head, and you're going to tell me if you can hear it bilaterally on both sides equally as loud.
Okay. That's yes.
Okay. And then the Rhine test tests for air to bone conduction, which should be 2 to 1. So I'm going to hold it on the back of your ear and tell me when you can stop feeling it.
Oh, there.
And then tell me when you can stop hearing it.
There.
Perfect. Moving on from the ears, I will then visually inspect the nose, making sure it is midline. I will visually inspect the nasal mucosa, making sure it is pink, looking at the turbinates for any nasal polyps, any unusual drainage or exudate, as well as looking at the nasal patency and looking at the septum to make sure it is not deviated. Okay, perfect. I will also test the patient's olfactory nerve by having him identify a familiar smell. So if you can close your eyes and then tell me what you smell.
Rubbing alcohol.
And then on the other side as well.
Still rubbing alcohol.
Okay. Okay, so moving on from the nose, we go to the mouth. Again, visually inspecting, making sure the mouth is symmetrical, noting the color and moisture of the lips. I'll have the patient open his mouth, looking at the oral mucosa, looking at the gingiva, making sure everything is pink, no redness or ulceration. Looking also for any mispositioned or missing teeth. I'll have the patient stick out his tongue, testing the hypoglossal nerve, as well as looking at the vascularization of the tongue. Can you lift it up? Perfect. And then stick out your tongue and say ah.
Ah.
Checking to make sure the uvula is rising midline, which is the vagus nerve. I will also test the patient's gag reflex. You can open up. Perfect, and the patient responds appropriately. I will then test the facial nerves by asking the patient to smile and puff out your cheeks. Perfect. And then the last of our spinal nerves is the spinal accessory nerve, in which I ask my patient to shrug his shoulders against resistance. Perfect. Okay, so then moving on to inspection of the neck. I first visually inspect the neck, noting that it is symmetrical, the trachea is midline, there's no accessory muscle use during breathing, indicating difficulty breathing. I will palpate my patient's thyroid by coming behind them, warning them that I'm about to place both hands around their neck and asking them to swallow. Perfect. I'm palpating the thyroid gland. I will then feel the carotid pulses one at a time, making sure not to occlude both simultaneously. Making sure there are 2 plus bilaterally. I will also listen to the carotid pulse, listening for bruits. Perfect, and then we're noted. I will test the patient's range of motion of the neck by asking you to try to touch your ears to your shoulders on the side, and then look up and look down. And then I'll also test muscle strength of the neck by asking him to turn his face against my hand next to against resistance. Just turn to the side. And okay, perfect. So then, moving on from the neck to the posterior chest, if I can have you spin around for me.
This one?
Yes.
Okay.
So first, visually inspecting the chest, looking for symmetrical rise and fall, checking for no accessory muscle use during breathing. I will then use my hands to check for expansion, asking my patient to take a deep breath in and let it out. And watching the space between my thumbs to make sure it moves appropriately. I will then palpate over the chest to make sure I feel no heaves or thrills or tactile firmitus. Can you say 99?
99.
Again?
99. 99.
Okay. I will then percuss over the entire lung fields, listening for resonant lung sounds, listening for any areas of dullness which could indicate fluid collection, or hyperresonance as in overinflation like COPD or asthma. I can also percuss for diaphragmatic excursion by asking my patient to take a deep breath in and hold it, and percussing up until I find dullness, and then having him breathe out. And now you can take a regular breath, and then when you breathe out, hold it. And percussing downward until I find the point of dullness and measuring the point in between those. I will also check for CVA angle tenderness. Is there any tenderness here? Over here.
No.
Okay. I will then auscultate the lung fields. I'm listening for any advantageous breath sounds such as crackles, rails, rhonchi, or wheezes. And just moving in a ladder-like pattern. Perfect, and breath sounds were clear and equal bilaterally. So that concludes the posterior chest. I can have you turn back around. I will then talk through the breast and axilla exam for both sexes. So first I would feel the axilla of the patient while sitting upright. I would feel for the axillary lymph nodes. And then for females, I would visualize the breasts in 4 different positions: hands at sides, hands on hips, arms above head, and slightly leaning forward, looking at the skin for any visible dimpling, changes in texture, color signifying inflammation, or any visual signs of breast cancer like orange peel skin. I would have the patient lie back and feel in a strip-like pattern in small concentric circles from the collarbone to the breastbone, and then from the sternum out to the axilla, feeling for any nodules, masses, or tenderness. I would feel also the axilla while the patient is reclining back, using my opposite hand to reach across the body, place my fingers under the pectoral muscle along the chest wall, and then run my hand down it, feeling for any nodules. And then the breast exam is equally important in the men, looking for any skin changes or any visible signs of breast cancer. So then I move on to my assessment of the anterior chest. Again, first visualizing for symmetrical rise and fall, no accessory muscle use during inspiration or expiration. I will palpate for heaves, thrills, and tactile fremitus, which there are none. I will percuss over the lung fields, listening again for those resonant lung sounds, listening for any areas of dullness. I will also palpate for the point of maximal impulse, which on this patient is fairly easy to find. I will then listen to lung sounds again, listening for any advantageous sounds, wheezing indicating asthma, or crackles or rhonchi indicating fluid in the lungs. And I will also listen to lateral breath sounds at this time. I will then have the patient lean slightly forward to bring the apex of the heart closer to the chest wall, and I will listen at the pulmonic, mitral, tricuspid, and Erb's point of the heart. Listening for that strong S1 and S2. And then also listening with the bell of my stethoscope to listen for any murmurs. And then we're noted just the strong S1 and S2 sound. I will then check my patient's jugular venous distension. So I'll ask him to lie back at a 30-degree angle. I don't have it adjusted there. Okay. I'll ask my patient to turn his head slightly away from me, finding the sternal angle with a centimeter ruler, and then using something flat like a piece of paper to measure the meniscus. I'm just measuring that highest point of pulsation of the meniscus, which should be about 3 to 4 centimeters. While I have my patient lying back, I'll continue with the abdominal assessment. So visually inspecting the abdomen, looking for any masses, visual peristalsis, or pulsations. I then auscultate first in the abdominal assessment, listening for bowel sounds in all 4 quadrants. And his bowel sounds are normal active. While I have my stethoscope, I will listen to the abdominal aorta, as well as the femoral arteries for any bruise. will then percuss over the abdominal field, listening for tympanic sounds, listening for areas of dullness or higher pitch sounds indicating dullness, indicating organs, higher pitch sounds indicating pockets of air. While I'm percussing, I can percuss for the liver span by percussing up from the umbilicus, listening for the area of dullness, and then percussing down from the midclavicular line to find that top liver border. And then I would measure the distance between those two. I can also percuss over the spleen to check for splenic dullness. I will then move on to palpation. First, light palpation, feeling over the entire abdomen, checking for masses, any areas of tenderness, making sure I keep an eye on my patient's facial expression for any tenderness. I'll then move on to deep palpation. So I place my hand behind my patient's back and feel for the liver border. It should feel smooth, which it is. And then also feeling for the right kidney. So there should be no tenderness in this area. And then feeling on the other side, palpating for the spleen, which I should not be able to find, which I don't. And then for the left kidney, making sure there is no tenderness. Okay. All right, so then I will move on to range of motion of the lower extremities. First, having my patient flex his foot and lift each leg, noting if there's any tenderness. This would indicate possible disc herniation in the back. And then while I'm here, I'm also looking at the peripheral vascular status. I'm looking at hair distribution. I'm looking at color, any discoloration, the temperature of the lower extremities, as well as nail bed color and cap reflex. I will do range of motion on the hip. So flexion, extension, adduction, abduction, and internal rotation and external rotation. And then the same on the other side. So flexion, extension, abduction, adduction, internal rotation, and external rotation. I will then do the same on the knees. So flexion and extension, and internal rotation and external rotation. And the same on the other leg. For flexion, extension, adduction, abduction, internal and external rotation. I will check range of motion of the ankles, having them flex their feet and then dorsiflex them, and check muscular strength at this time by having them push down on my hands on the gas pedal. Perfect. While I'm here with also the peripheral vascular status, I'm checking the pulses. So I'm checking the dorsalis pulse, the posterior tibial pulse, and then the popliteal pulses with both hands. Making sure they are all tubeless. Okay. So then, if I can have you sit up on the edge again, I'm going to do the range of motion of your shoulders.
Okay.
So if I can have you raise your arms up and adduct them, crossing over, and abduct them, and then external rotation behind your head and internal rotation behind your back. Perfect. And then I'm going to do range of motion of the elbows while also checking muscular strength. So I'm going to have you put your arms out and bend your elbows towards you against my hands. Perfect. And then I'm also going to check rotation of the wrists. So if you can pronate and supinate them, and then do it rapidly, checking for cerebellar function. Perfect. Okay, So I'm also gonna continue with checking the, hands, fingers, and knuckles. Also checking peripheral vascular status, checking the radial pulses and the brachial pulses. Perfect. Continuing with the cerebellar tests, I'm gonna have you close your eyes and hold out your hand. And I'm gonna trace a number in your palm, and I want you to tell me what number I'm drawing.
3.
Okay? And then I'm also gonna place a object in your hand and have you tell me what it is. You can feel of it.
Time.
Yes.
Coin.
Perfect. Okay, now with your eyes still closed, we're gonna do point-to-point testing. So I'm gonna touch a finger, and then I want you to use that finger to touch your nose.
Okay.
Perfect, okay, you can open your eyes. And then we're also gonna do point-to-point on the lower extremities. So I want you to take the heel of one foot and run it up the shin of your other foot. Back down, and then on the other side as well. Perfect. I will now check your reflexes. So I'm gonna check the tricep reflex. And just relax your arm. The bicep reflex. Radial reflex. Patellar reflex. And then the Achilles reflex. And I would do that bilaterally on both sides. I am then gonna have the patient stand and have him close his eyes, checking for ataxia. This is the Romberg test, making sure he's not gonna lose his balance. Perfect. You can open your eyes. And then I'm gonna ask him to bend over and touch your toes as far as you can. And I'm looking at the spine, making sure it's straight and midline, checking for any signs of scoliosis. I'm also checking for any CVA tenderness at this time. And if you can come like halfway up and flat back. Perfect. And again, checking, making sure the spine is midline and straight. Okay. So I'm then gonna ask the patient to walk, checking their gait. If you wanna just walk to the scale and back. Checking the range of motion, the muscular strength. And then I'm also gonna have the patient walk away from me on his toes and back to me on his heels. Perfect, you can have a seat. So I'm now gonna talk through the male and female genital assessment. Before either sex, I'm gonna make sure they're draped appropriately and I've obtained consent. For the male assessment, I'm gonna assist them into a left lying position. I'm first gonna visualize the skin of the perianal area, the anal area, and the peritoneum. I am then going to do a digital rectal exam. I'm gonna feel the tone of the sphincter, feeling the anal canal, making sure it's smooth with no ulceration, no lesions, no nodules or tenderness, moving in a clockwise pattern. Sweeping further clockwise, I'm gonna feel the prostate, checking the size, the shape, the consistency, and the motility of the prostate. I am then going to visually inspect the skin of the penis and scrotum. I'm gonna check both the foreskin and the glands of the penis for any ulceration or any discoloration, nodules. I am palpating the shaft of the penis, checking for any differences in consistency, any masses or tenderness. And then I'm also gonna palpate the contents of the scrotum, checking for both testes and the spermatic cords. In the woman, I'm going to assist her into a lithotomy position. I'm gonna make sure she's properly draped. I'm first gonna inspect the outer skin of the vulva and the perianal area. I'm then going to warn my patient that I'm about to introduce a speculum after making sure I've correctly selected the size of speculum for my patient. I will introduce my speculum in a closed position until it is fully inserted, then open it up so that I can visualize the cervix. checking for any exudate, any drainage, assessing the color, size, and making sure there are no lesions on the cervix. To do a pap smear, I will insert either the cervical broom or the cervical scraper into the os of the cervix and then slowly remove it. As I'm finishing up my internal vaginal exam, I'm going to slowly retract my speculum, inspecting the vaginal walls as I go, looking for any ulceration, changes in color, any unusual drainage before completely removing my speculum. And then the anal exam would perform much the same as it would on a male patient, with the exception of you can perform a bimanual exam of a woman in this position to feel for any masses higher up in the anal cavity. Summarizing my findings, my patient is alert and oriented. His vital signs are all within normal limits. All findings were to be expected. His range of motion is normal. He has no detectable abnormalities in his head, eyes, ears, nose, or throat, respiratory, cardiac, abdominal, musculoskeletal, or neurovascular areas of the body. Thank you.